Hi, Teesha Thompson. I was on 9100 neuro floor. My client was a 68-year-old female who was admitted for frequent falls due to dizziness. She states she had been falling for the past 2 months. She was initially admitted with a diagnosis of syncope and difficulty walking. She was being seen with the neuro team. They gave her a full body workup and an MRI. Nothing concerning with her MRI or her labs. She has a history of bipolar mix, depression, anxiety, PTSD, a total thyrectomy, right and left total knee placement, removal of peripheral neurostimulator pulse generator, or oophorectomy, hysterectomy at 46, uh, colonoscopy, breast biopsy, and one key finding that she shared with the nurse was that her and her daughter were switching the dosage of her medicine, whether she was getting too little or too less. They were kind of titrating her medication, and she is polypharm, so she has a lot of medications she was taking. Some subjective data that she shared was she feels dizzy while sitting, and when she gets up, she wasn't complaining of any vomiting, but she was complaining of some nausea. There is no numbness or tingling in her upper or lower extremities. Objective data, her temperature was 98.3. We performed a orthostatic hypotension with the doctor, and those three findings were 137 over 80, 114 over 68, and 108 over 57. And he was able to rule out an orthostatic hypotension. Her heart rate was 70, her respirations were 18, her oxygen was 96 on room air. ANO times 4, pupils round and reactive to light, 3 mm's in both the left and right eye. Patient, she had an MRI, she had her orthostatic hypotension test. Her labs were, her glucose was 116, her calcium was 9.4, her AST was 19, her ALT was 20, her vitamin B12 was 529, her hemoglobin was 12.3, her hematocrit was 37.3, her platelets were 263,000, her potassium was 3.4, her sodium was 138, her BUN was 11, her WBCs were 7.2. Some additional data that I asked and obtained, I wanted to ask her, where was she having any difficulty with walking, or I'm sorry, for her to tell me more about the difficulty she was having while walking. I asked her questions like, are you standing up too fast when you're getting up? Do your legs feel heavy when you walk? Are your legs shaky? Tell me more about your dizziness. Is it constant? Um, are you doing something before you get dizzy? Are you dizzy while sitting down? Does it feel like the room is spinning? Are you having any blurred or double vision? Are you having difficulty or new onset of vision change? Do you feel pressure in your eyes or anywhere in your head? Are you nauseous? Any sensitivity to lights? I asked all of those questions because I had a speculation diagnosis, and also I just wanted to perform like a basic neuro assessment and just to kind of make sure all of the grounds were checked for a neural assessment, and seeing if I, just knowing her baseline, seeing if I seen any abnormal assessments, so that way throughout the shift I would be able to monitor that. And my findings were significant. After assessing the patient, I felt comfortable ruling out any neurodiagnosis. I know that I'm not physically a doctor, but I have, a nursing diagnosis for my patient. After all of her vitals and her labs came back normal, my patho behind it for my patient is my patient was unstable while ambulating due to dizziness, unsteady, and loss of balance. With her gait, she was not anemic or iron deficient, which could reduce her oxygen, not allowing enough oxygen to go to her brain or muscles, contributing to dizziness, fatigue, and impaired coordination. She was at a higher risk for falls due to her being unsteady. So my nursing diagnosis was activity intolerance related to vertigo and dizziness, impaired physical mobility related to vertigo, and then risk for falls related to altered balance and impaired mobility secondary to vertigo. And the data was saying to me, like, what else can be causing the dizziness? If it's not neuro, what is something else that it can be? I am familiar with vertigo and just knowing some of the telltale signs of vertigo. And so I began to advocate for my patient. When I saw the physician around, I asked her, I noticed that you guys performed an MRI. There was no data from that. I know that you guys have performed some other testing for her. Has anyone ever tested her for vertigo? And he then said, no, we haven't. That's a good idea. So I was able to come into the room and see him perform the Dix Hall-Pike maneuver, which then confirmed a positive test for vertigo. And she was already planning to be discharged that day, or not that day, but just kind of doing an out roll of that. And so moving forward into my planning phase, my priority was safety and keeping my patient free from falls. I made sure to have her get up slowly when ambulating. I also had her rest with minimum noise and just have periods of rest with relaxation, her eyes closed, dim the lights. My patient was able to safely discharge and refer to an outpatient physical therapy for her vertigo. And my SMART goal was, by the end of my shift, patient will be discharged without having any more falls and educated on precautions for dizziness. My goal was met. The patient was discharged safely without having any new falls. The interventions were review all medications with patient, an understanding of meds prior to discharge. The rationale was polypharmacy increases dizziness. Encourage use of walker while walking. The rationale reduces the risk of falls. Collaborated with health team concerning patients' diagnosis of newly vertigo, and the rationale is supported patients' needs and goals to receive outpatient rehab. Educate patient on getting up slowly and watching her environment. The rationale was lessens the risk of dizziness and watching for the patient's pets, as they can be a tripping hazard as well. As the RN, I completed all 4 of the interventions. My highest priority was health promotion and safety. I was able to collaborate with the doctor to advocate for my patient and getting her tested for the vertigo. Helping the patient to the rest, I was able to delegate to the NA to help the patient to the restroom, and just reassuring that she uses her walker as she's up and ambulating. If there was ever a time she would call and I wasn't around to answer the call light. The evaluation, the SMART goal was met as the patient was safely discharged and educated on her needs, meds and diagnosis, keeping her free from falls. The data and information that showed we're working was the patient felt relieved. She still had some of her dizziness. She wasn't as anxious of not understanding what was going on with her. And she was happy to be able to get back to her home and just kind of taking small steps into getting into her active life with her grandchildren. My top 4 priorities was health promotion. My patient was getting discharged and I wanted her to make sure she understood her medication and her new diagnosis of vertigo. And, just about the outpatient experience as well. Number 2 was safety. I wanted my patient to be safe, safe while getting up slowly, using her walker, scan the environment for her pets, and just watch for tripping hazards. Number 3 was psychosocial integrity. My patient has some past medical history of anxiety, depression. She was anxious during her stay, but once she knew what was wrong, she calmed down. Also, having vertigo can be limiting when you want to go out places. You have to take frequent rest breaks because of the dizziness. Comfort. My patient has chronic back pain that's constant. She has a history of fibromyalgia as well, arthritis, and the chronic back pain and migraines. So she's always in pain. Her pain was constantly at a 6 for the day. The connections that I want to make is health promotion to tissue integrity. A priority problem not related to death could be my patient falling and having like a broken hip or so, and then just having to get a surgery for that impairs her tissue integrity, and then also kind of not being able to fully move around a lot can impair her tissue integrity while she's dealing with the vertigo. I connected safety to mobility, just making sure she uses her walker, scans her environment to keep herself safe from any falls, and mobility as well. She kind of has an impaired, when I say impaired mobility, just not able to really move around so much when she's feeling moments of her dizziness. Psychosocial social integrity would be connected to culture. She is a Christian and focuses on God to help her for her mental health. And she was experiencing a lot of anxiety during this stay, and not having, um, being worsening depression because of what was going on. I wanted to connect comfort to, it can connect to mobility, psychosocial integrity, safety as well, because of her being in a lot of pain. It was causing her not to sleep as much, and just having her past medical history of the chronic pain can contribute to all of the concepts that I just mentioned. And my reflection during clinicals, I really improved on just my clinical judgment and prioritizing tasks by making a prioritization checklist at the beginning of the shift for the patients that I was caring for, and then just being able to communicate professionally with the staff and collaborate with the team through messaging. I would like to take that experience with me as I continue my career in the next semester, and well, just in my career in general as a nurse. Just advocating for my patients and being the voice of reason for them, and just having therapeutic communication when speaking with them. I also really appreciated having feedback. It helped me improve on the areas that I needed improvement on, and that was just very nice to be able to take that with me. So those are the things that I would take with me when I become an RN, and just continue to develop my skill.